Good morning, good afternoon, and good evening to everybody who is attending this session. I'm hoping that you are having a wonderful day. My name is Gabriela Cipriano, and I'm part of the AMEE Student Task Force. I'm running the show behind the curtains here. I have the pleasure to be helping this exhibitor workshop on behalf of CyberPatient. So our first speaker would be Dr. Qayumi here, and he will be developing the session alongside his colleagues from CyberPatient. So I hope that you enjoy the session. Dr. Qayumi, the platform is all yours.
So I don't know how to start with these conferences. I can say good morning, good afternoon, good evening, because for me it's good morning. For some of you it's good afternoon, and some of you it's good evening. Anyway, dear colleagues, ladies and gentlemen, first of all, I would like to extend my appreciation and gratitude to the AMEE Conference Organizing Committee and to Gabriela for giving us the opportunity to do this workshop. Our workshop consists of three parts that has a specific learning objectives. Part one would be lecture seminar type. By the end of this part, you will be familiar with educational theories behind experiential learning. You will be familiar with the concept of virtual simulation in health education, and you will understand how CyberPatient can support your education. Part two of our workshop would include a CyberPatient demo, and my friend and colleague, Dr. Shahriar, will do the demo for you. So by the end of the second part, you will be familiar with the CyberPatient interface and how it works. In part three of our workshop, you will have a hands-on experience with CyberPatient. And by the end of this session, you will be able to use and operate CyberPatient platform to support your competency-based education. So with your permission, I will start with part one, talking about medical education. As you all perhaps know that in classical medical education, we have three important methods. It's chalk and talk, which means lectures and seminars. It's reading books and giving assignment to students. And also it is see one, do one, and teach one, which is called also apprenticeship model. Let's see which one of these models are the most effective. So national training laboratories in United States have demonstrated that after 3 months, the knowledge retention for lectures would be only 5%. You're going to remember today, whatever I said to you, only 5% of it in 3 months. So reading is about 10%. If you add audiovisuals into your lectures, would be 20%. If you have a demonstration, it would be 30%. If you have a discussion group, such as CBL, PBL, it would be 50%. And practice by doing is about 75%, teaching others in 80%. Now we know that the knowledge retention here is the best for practice by doing. And let's see what are the theoretical basis for practice by doing, learning by doing. So learning by doing is based on constructivism theory of very famous pedagogue from Switzerland, Piaget. So Piaget said that learning is secondary to and dependent upon progressive reorganization of cognitive function. To teach, Piaget said, is not to reshape behavior, but to provide the environment for students to self-explore. Now, we know now that computers are the best tools for constructivism theory of Piaget for learning by doing. Now, another pedagogue philosopher from Russia, Vygotsky, brought another dimension to the constructivism theory. And he said that learning is a social environment. We learn from each other. So it's wrong to assume that if we gave a tool to a student and isolate them, would learn anything. Therefore, he brought up a theory of social constructivism. Now, we know that computers are not only as silos, because with internet, now computers are becoming the biggest social creature in the world. So coming to conclusion saying that learning by doing, and that's based on constructivism theory of Piaget and social constructivism theory of Vygotsky, is very good, suitable for modern internet-based platforms and computer-assisted learning. Let's go back and think a little bit about how do we gain competencies in medicine. So how do we make a clinical or diagnostic or management decision? So research has shown that there are 4 types of thinking. There's reduced thinking, dispersed thinking, elaborated thinking, and compiled thinking. We're not going to talk about reduced and dispersed thinking because we don't teach medical students on the basis of empty mind or clustered mind. But the biggest method we use is elaborated thinking. So elaborated thinking is based on deductive reasoning. So what it means that we teach students how to gather clues from history taking, from physical examination, from lab tests, and make a conclusion, a diagnostic or management decision. But this elaborated thinking, although it's a good tool, but it's very much time consuming. But when the students are finishing medical school and they go for practice, in the next 3 to 5 years, they can see a patient within 5 to 10 minutes and make a diagnostic decision just like that. And they're doing this not because they ignore patients, it's because they are working on another level of thinking, and that's called compiled thinking. Compiled thinking is based on recall, recognition, memory. If a doctor, I've seen hundreds of patients with the same symptoms and the same problems. Next time when a new patient comes, he uses the prior experience to make a fast diagnosis. Automatically, they come to a conclusion, the decision for that clinical event. So let's see now how recall, recognition, memory is done. So recall, recognition, memory is based on Hofding's theory of transfer of learning. Now, we have to distinguish that there is a difference between transfer of learning and transfer of knowledge. Transfer of knowledge is from one person to another person. Like I'm talking to you now, I'm learning from you, you're learning from me. Now, transfer of learning, on the other hand, is from the same individual to the same individual. And how our prior experience or encounter affects our present experience or future experiences. So let's see how this recall recognition occur. So I apologize for this very complicated slide, but I would like you to not pay attention to the complexity of it because I will explain it to you in very simple words. So if you have here, if we have a prior encounter or the first encounter, it goes through our sensory reception, sensory perception to short-term memory and long-term memory. And then it identifies a few neurons that clusters into nodes and form certain pathways to communicate with each other somewhere in our hippocampus in the brain and our subconscious mind. So when the new encounter, and that's why that we call this semantic network, because they have the same, they're after the same meaning and the same references. So when the new encounter occurs, it goes to the same pathway into our brain, and then the brain would recognize, oh, I have had this experience before. So it triggers this semantic network. And through that semantic network, then I will do automatically the new encounter, and I don't have to even think about it. And that's called the identical element theory of transfer. When the old or the past experience is exactly the same as the new experience. Now, the question comes like, what happened if the previous experience is not 100% exactly the same as the past experience, if they're a little bit different? And to answer in the question is, can our brain recall that semantic network that is conceptually similar to the previous one? And the answer is yes. And the cognitive theory of transfer explains how a conceptual similarities will support the transfer of learning. And the mechanism how it happens was explained very well by Chan in 1993. He did a very good quantitative analysis in experiments, and he recognized that there are certain levels, mainly 4 levels for this transfer of learning that occurs through cognition when you have a similar but not exact prior experience. I'm going to give you, the first one is called connection. So I'm going to give you just an example. Because I'm a surgeon by training, I'll give you a surgical example, okay? Let's say my students are coming to me to learn knot tying techniques for a seminar. So I'm explaining the knot tying techniques to my students as a new encounter. But all the students knows how to tie their shoelaces. So they tying their shoelaces, their mother told them how to do that, hopefully. So they actually, the brain brings that similarity, that concept up and connect it with the new encounter. And that's why it's called connection. So in pedagogy, it would be orientation. So when I do orientation, the new encounter would attach to a semantic network that is already in my brain, and start building on that to make it more sophisticated. So then I'm gonna start coaching students, take their hands and make sure that they know how to do the knot tying techniques, and then they will develop more. As you see here, the red ones, some of these would solidify, some of these would disappear, some new pathways would open, and new neurons clusters were open. And then slowly, when I train them, then they learn it very well. But now I have to fine tune them. Like, for example, if they do the first knot, but they cannot keep the first knot in place when they do the second knot, or they cannot do left and right hands or something, then I teach them those things, and then they will practice and practice and practice those small little tuning up details. And once, and that's called accorrelation. So, and then they go to the final stage of solidification, when they practice this so much that the new encounter with the old encounter together, forming a new cluster, solid new cluster that would make the students to do this automatically. And it's called routinization. So the problem with medical education is that most of the competencies, it's not just knot tying technique, all the competencies go through the same stages. But in medical schools, most of the competencies are done in a clinical environment using patients. And that would make the learning competencies makes more expensive, and it's more time consuming. And at times it jeopardizes the patient safety. Now, in modern education, using these cognitive stages of transfer of chain, we can actually isolate the first three stages and teach them in laboratory or simulation labs or by virtual simulations such as CyberPatient. So we can do the connection, accretion, and articulation all in the simulation lab or with CyberPatient. This would make the learning process less time-consuming. It would make it less expensive, and it's also support the patient safety. And then we're going to transfer this into a clinical, conditions for solidification. So when some people think that, oh, simulation cannot replace clinical teaching, of course it cannot. No virtual environment would replace clinical encounters. No simulation, physical simulation labs would replace the clinical encounters. But what we are saying is that we have to prepare students to go through those three stages in a safe environment, in a laboratory or virtual environment before they have a clinical encounter. And then when they do the clinical encounter in these conditions for solidification, the medical education would be, clinical education would be more efficient, faster, and safer and more ethical. So going back to classical method of see one, do one, teach one, or apprenticeship model, now we know that people should do years of clinical practice to gain compiled thinking and to improve their competencies. And if you look at our residency training program, it takes 3 years in the whole entire world for the students to slowly go into automatization and solidification in independence. Only in year 3 and 4, we let the residents to work independently. But with the use of simulation or simulation environments such as CyberPatient, if we do C1 and then simulate 101 with CyberPatient and then do one and teach one, then what we can do is we condense this time, and in months with CyberPatient, we will gain that compiled thinking and improve our competencies. So within 1 year, we're going to be able to give the students the opportunity to work independently. Now, the second issue that I would like to explain is virtual simulation, because there are a lot of jargons in terminologies thrown in the environment, such as virtual simulation, virtual reality simulation, augmented reality simulation, mixed reality simulation, and others. I don't have time to talk about augmented and mixed reality simulation and others, but I like to identify the difference between virtual simulation and virtual reality simulation. So virtual simulation is the recreation of a real event or a process depicted on an interactive computer screen, where the virtual reality simulation is when the system, in addition to the interactive computer screen, it uses other equipment and technologies such as goggles, glasses, such as haptic interface of sensory motor reactions, such as pressure points and things like that. So I have to admit that CyberPatient is not a virtual reality simulation. It's a virtual simulation. So I just wanted you to understand that difference. So by definition, CyberPatient is an interactive learning platform that closes the gap between the theory and practice of medicine and provides a virtual environment for students to gain competencies. In reality, CyberPatient is a virtual hospital with 125 digitally enhanced patients that is available for students 24/7. They can go there and reach it and study with it. And students can practice in a very safe environment. And it's also less expensive. And I'll show it to you what do I mean by that. Our research in different areas in Japan actually demonstrated that CyberPatient is significantly more effective than textbooks. At UBC, our research has shown that CyberPatient is as good as a standardized patient, but it's only 10% of the cost of standardized patients. So it's much less expensive than standardized patient. And also our survey at Kazan State Medical University and in Russia have demonstrated that 90% of our participants reported that they gain better competencies and they are more confident than they were before after the CyberPatient. So I can say that pedagogical values that CyberPatient has for students are not limited to those I'm going to describe here, but these are the most important one. It's an outstanding tool for student-centered education, for competency-based education. It improves decision-making abilities of students. It improves experiential learning. It accommodates style of learning. It improves compiled thinking and provides a solid base for transfer of learning, as we discussed before. It is also very useful for faculty. It provides patience 24/7 for faculties. I do remember at my time, I could not sleep at night to think like how many students I have in the ward and how many patients do I have? Do I have the same kind of patient I can teach this disease or not? It's a big dilemma. But now you have a virtual environment with 125 patients that you can reach at any time with any pathology. And it benefits also the university because it reduces the cost of education. And it also benefits the healthcare system because it may reduce the medical errors. So in summary, I can say that now we understand how virtual simulation technology supports experiential learning and competency-based education. It's by increasing the efficiency, by reducing the cost, and consolidating the time of learning and improving patient safety. We now understand that virtual simulation is different than virtual reality simulation, and CyberPatient is not a virtual reality. It's a virtual simulation platform that will support your competency-based education with online hospital in 125 digitally enhanced patient that covers from head to toe all the systems that you can think of. So in the end, I would like to cordially thank again every one of you for participating in this event, and for those who's going to listen to this afterward. And I would like you to know that you can reach me or Mark Ritchie. You have the emails and telephone numbers there. We will be at your service at any time you like us to do. And now we're gonna jump into the part 2 of our workshop, which is CyberPatient demo. And by the end of this session, you will be familiar with CyberPatient interface and how it works. I have to admit, and for you to understand that CyberPatient platform is much, much bigger than this demo that you are going to see. CyberPatient has not only patients, but also we have a case management system that is adaptable to any learning management system you have in your universities. And that case management system that we have, the students in university can create classes, they can assign students to those classes, they can also assign cases to those classes, and most importantly, that the faculty would be 24/7 connected to the students and will be able to provide formative and summative assessment of the students. In this demo, we're gonna show you just how CyberPatient works, but to understand the whole platform in also the case management system, you should be able to participate in part 3, hands-on experience. And you can see the link down there. Mark has also perhaps put that link in the chat room, so you can get it from there. But he will be also in contact with you to support you. So you will have the hands-on experience later on, and I hope you would enjoy it. So at this time, I would like to ask my friend and colleague, Dr. Shahryar, to give you a very superficial demonstration of how CyberPatient works. Thank you.
Thank you, Dr. Qayumi, and thank you, everyone. Please let me share the screen. Okay, so this is the login page of the CyberPatient platform, where I can log in as a student that Dr. Qayumi mentioned. So we have a different level of the simulation in the CyberPatient. I'm logging as a student in the platform, and in my dashboard, I can see the list of my class, and I can see the last performance score, and I can see the levels. So CyberPatient has 4 levels. So those levels are actually customized based on the clinical competencies of the student. So level 1 is history taking, level 2 is history and physical examination, level 3 is full management of the patient with failure. That means they can make a mistake and they can learn from their mistake by the feedback that CyberPatient machine give them. And level 4, where they can basically practice on their competencies without failure. That means if they make a mistake, the system basically reset the case and they have to start the case from the beginning. So for this demo purpose, I create a class already, and I assign to one of the students. This is me, and I can see in my dashboard my recommended level of the skill that I have to practice on, my information of the class, and okay, I can see my professor assigned me 6 cases. And there is no grade, no average, because I haven't done any cases so far. This is the list of my assignments. Those are cases from GI system, because I am in the rotation of the gastroenterology. So that's why my professor decided to assign me all the case from the GI system. As Dr. Qayumi mentioned, we have more than 125 cases in the case library of the CyberPatient. Those are categorized based on the system, every system from head to toes. Also, here is the my history. If I've done any cases, I can see the history. This is a place for feedback from my professor, and this is the summative assessment place. When I'm done with this course, at the end of the course, my professor gives me a summative assessment that shows me if I pass the course or if I fail the course, plus some feedback from my professor. So let me go to the platform and show you how the case actually works.
Hello, I'm Dr. Smith. I'm the on-call doctor today.
Hello, Dr. Smith.
So every case started with the history taking. So as a standard things for every medical student. So where we basically categorize all the questions related to the chief complaint here on different category, including patient information, chief complaint, history of present illness, and this categorization is actually a standard categorization of the history taking. And a student can go through each section and ask question from the patient. For example,
what is your name and age?
Jeremy Ramsey and I am 37 years old.
What seems to be the problem today?
I have heartburn and burning pain in my lower chest.
When did the pain start?
2 months ago.
So usually the novice student using the categorization because they don't know which question is important for the diagnosis and which one is not. And the intelligent tutoring system that we have in the back of the CyberPatient basically scored the relevant question to the chief complaint. And we showed the irrelevant question as a red, highlighted as a red at the end in the feedback for the student. So the student can get a feedback at the end of the case to see, okay, which question are relevant and which one is irrelevant. So more advanced student using the search menu, they can ask the question from the search menu, and all they just need to write the keyword here and ask the question from
Where was the pain when it
patient.
started?
In my stomach.
Are you currently sexually active?
Yes.
An interesting thing that we have in the CyberPatient is translation. So where we can basically translate the whole platform to more than 70 language, including French, everything. So, and they basically can translate whole platform to different language. So when the student done with the history taking part, they have to document their finding, their data that they gathered from the history taking. We have a patient chart here where a student can basically chart their finding, and they can go through every section of the case, including exams, investigation, diagnosing, and so far till end. And they have to document every finding of the history taking, and also every measure that they have done during the case. This chart is savable, and they can download this chart for their record at the end. After patient history, the next step would be physical examination, the most interactive part of the CyberPatient.
Thanks for the information. At this time, I would like to do physical examination. Please let me know if you feel uncomfortable. I will wash my hands before we start.
Basically, we categorize all the physical examination to two categories: general exams and special exams. General exams will start with the vital signs, where student can check the vital signs. So we simulate the checking the pulse control, blood pressure control, and so on. For example, for the pulse,
Please give me your wrist so that I may check your pulse.
they have to start the timer, they have to check the number of the pulse, and they have to write it down in the chart. For the blood pressure,
Please put your arm in this cuff so I can check your blood pressure.
they have to pumping and check the blood pressure by using the device, and we simulate the cord cuff sounds for the blood pressure. In order to examine the patient from the close, they have to zoom in on the patient and bring the patient to close themselves.
I'm going to take a closer look at your head.
Now they can use some instrument here to check to examine the patient.
Please tilt your head up so I may use this speculum. Please let me use this tongue depressor to examine your mouth. Please sit still so I can use an otoscope to examine your ears. Please look into the light on the ophthalmoscope.
And if there is any abnormal finding in the physical examination, so basically we show them what is abnormal, and they can get the diagnosis from the examination. If I want to check the heart and lungs, I have to zoom in on the chest.
I'm going to take a closer look at your torso.
I can listen to the heart.
I will use my stethoscope to examine you.
And you can see there is a different type of sounds here based on the different area of the heart, like mitral, tricuspid, and pulmonic and aortic, and all of these sounds are anatomically correct, and they can learn from the sound. If I want to check the lung, I have
Please
to turn around my
Please
patient
turn.
and listen to the lung.
I will use my stethoscope to examine you.
So vesicular sounds and the bronchial sounds, all anatomically correct. In order to examine my patient in the laying down, I have to lay down
Please
my
lay
patient.
down.
And now I can use some method of the examination, including palpitation, percussion, and auscultation here, for example.
I will investigate using my hands. Please let me know if you feel uncomfortable.
I can palpate the abdomen, looking for any abnormality.
Yes, that's where the pain is.
And you can see the avatar basically show the student what is the abnormal finding in the physical examination. And if there is any abnormality here, we show them what is the problem. In order to complete the physical examination, sometimes we need to do some special tests. In the special test, we have a list of the whole special tests that we adopt from the Bates physical examination and history taking textbook. We have a list of the examination from head to toes here, and a student can go through each section and find the test that is relevant to the case. And all these tests are scored by the CyberPatient intelligent tutoring system. Another way to find the test are using the search. For example, for this case, I would like to check the Morphy test. So, and the system animated this test to the student, and they can find if this test is positive or negative.
I'm going to check your gallbladder. Please let me know if you feel any pain. Please take a deep breath in.
And when I'm
Murphy
done,
test is negative.
when I'm done with the physical examination, I have to go through the chart and basically document all my finding in the chart.
After examining your patient, do you believe they require any immediate care?
Now we involve the student with the decision making if the patient needs any immediate care. Actually, this is one of the competencies of the student.
What is your provisional diagnosis?
Now they have to think about a differential diagnosis for the patient.
Please select the lab tests that you require.
And now they have to basically test their their provisional diagnosis, where we have a list of the physical lab tests here that we categorize all of them to 3 big category, and they can find the lab test that they want. They also can go through the search and just write the test, for example, a CBT, and they can see the result right away, and it helps them for the decision making. If I want to do, for example, ECG for my patient, I can see the ECG right away. If I want to do, for example, X-ray for my patient, I have to just write the X-ray and find the X-ray that is relevant to the patient, and I can see the result and the brief report. If I want to, for example, do the ultrasound, I have to find the ultrasound that is relevant to my patient. And see the result. And again, when I'm done with the lab test, I have to go through the chart and document my finding in the chart. The next
What is your
step
final diagnosis?
would be final diagnosis based on my history, my physical examination, my investigation results, so I can find the final diagnosis. And if I'm doing actually choosing the wrong answer here, the system will give me an instant feedback.
Incorrect. Please try again.
In order to going forward, I have to choose the correct answer to be able to go forward.
What would be your management plan for this patient?
Now, this is a time for involving with the management. I have to choose what is the management here.
That's correct. How would you like to proceed?
As a student, I have to think if my patient need any hospitalization, observation, or I would like to discharge my patient from my service. And now this is the time for give the patient some order, like activity, what would be the activity, and what would be the diet, and choose the diet and activity. I have to give my patient some recommendation. For example, stop smoking for this case, or anything else like dietary modification. And we have a list of the recommendation here that I can choose.
Please choose any referrals that your patient requires.
Now this is a time for another competency. So making a consultation with other colleagues. So I have to choose if my patient need any referral. And now this is the time for prescription for my patient. There is more than 4,500 medication in the database of CyberPatient. A student just need to choose the medication based on the gold standard of the treatment. For example, for this case, I would like to give my patient one of the PPI, and I have to choose the name, I have to choose the frequency and the duration of the treatment. And when I'm choosing the medication, the prescription coming here, and you can double check the prescription, and even you can give the patient some instruction for the using medication. For example, taking your medication after meal, before meal, or whatever, and then go to the next step. Now this is the time for arranging the follow-up with my patient and educating my patient basically, and I can arrange a follow-up with my patient. At the end, I have to double check if I document everything in the case, in the chart, and then finished.
You are ready to go home now. We wish you a speedy recovery.
So the interesting part of the CyberPatient is coming here, where we give the student an instant feedback for their performance. So basically, we have an overall score for the student at the end that is breakdown to knowledge, time, and cost. So the knowledge score basically is breakdown to different parts. That means it's basically the average of the score of the student performance on each sections, including history, physical, and so on. And a student can check their performance based in each section. For example, I want to check my performance in the history taking part, where I can see, okay, I did very bad. And so why I did so bad, I can check my feedback here, and I can see, okay, this is a correct choice that I had to ask from my patient, and this is my choices. And actually, one of them is not relevant to the case. And I can learn from my mistake, and I can try again the case. And in the next time, I have to take into account, okay, these questions are basically correct, and I have to go for this. I can basically check all the section and the feedback and everything here. On the diagnosis, as you remember, I made a mistake in the final diagnosis, and the system deduct my score to 50%. I can check my chart at the end, and I can see my documentation here. I can download this chart for myself. Okay, now I'm finished with my review of performance. And actually, the interesting thing is my professor can see my performance here, and they can basically give me an feedback for my performance as soon as they see my performance. Another thing here that we have in the CyberPatient is educational resource. If I have any question from the patient, from the examination, from diagnosis, I can go through this educational resource, where we have more than 700 modules that we categorize those modules for the students, and they can go through each section and find a very valuable information from the case. For example, I have some question from my how to examine the thorax and lungs. I can go here. There is educational content here where I can update my knowledge. And also there are some web objects here that the CyberPatient basically provided to the student for the examination. For example, let me just show a short part of one of these web objects.
Crackles can be heard during inspiration or expiration. Fine crackles can be caused by collapsed alveoli popping open during inspiration and may clear with deep breathing.
So basically, a student can learn a lot from these modules. And I don't, because of the sake of time, I don't want to take your time because you have to basically practice on our classes after this session. When I finish my case, I can go back to my home and I can go here and I can say, okay, I have done one of my cases. And interestingly, my professor have seen my performance, and my professor gave me a feedback right away. Okay, I have to, work on this and that. I have to check the, Bates guide for the history taking and so on. And as a professor can give the student many time feedback. And basically, this is a two-way communication between the student and the professor. So I guess I'm done with the, it is very superficial overview of the, CyberPatient. So this case was one of the short cases from the, outpatient setting. So we have a cases that we have done surgery, procedure, and, in the hospital setting. So yeah, that's it. So, Dr. Karim, Dr. Qayumi, do you want to add anything?
No, just yeah, quit. Now it's time for questions and answers. If anybody has questions, I would be more
Thank you, everyone.
Entertained. I guess I have already a question here from Dr. Yep. If I'm pronouncing right, I apologize if my
yes, that's correct.
Okay, great. Thank you very much. So Dr. Yep is saying that maybe the cost of this device, simulation learning device, would be not less than the clinical or maybe even cyber standardized patients. I think Mark would send you the paper that we published from UBC. We're working based on UBC data. According to our UBC, University of British Columbia data, we spend about $120,000 per year for standardized patients. And we can have only maybe 3 cases the most for the students to have experience with. And in 3 cases, 3 times a year, it's going to cost $120,000 for each student. And the reason for that is that we have to train the artists. You have to pay the artist. You have to pay the trainer to train the artist. And they're not very constant. They change very fast because if they find another job, they're not going to do this anymore. So, and then you have to pay the students to come to this, you have to pay the artist to come to the class with the students, and you have to pay the teacher to be with the students. So combining all the cost of standardized patient, we believe that CyberPatient will provide the same experience with 120 patients, not 3 patients. If you multiply that $125,000 to 120,000, some universities spend less. Universities are usually spending from 80 to 120,000. Even if you spend $100,000 per year as an average for your standardized patients, you gave the experience for your students only for 3 cases. While if you use CyberPatient, it's endless opportunities for them to have this in its for 125 different cases in different experiential environments. So assume that if you had the whole army of standardized patients, you will not be able physically and in financially to support all the cases that that medical schools are going through. So that's how it's calculated. But you're most welcome to look at our paper and give us a feedback. Appreciate your question.
Thanks. The only thing is, my comment is that at least in my country, we don't use standardized patients for the full works of investigation. When I look at the skills, there are two as components: recurrent and the non-recurrent aspects, right? So procedural skills, those you use simulators, this will not be this will be very good for clinical reasoning and trying to simulate a scenario. But the procedural aspects, I think this is, like you say, this is a virtual reality and not a virtual reality simulation. So I guess, but I'm actually quite impressed, with the range of cases that you have to try to, in a way, simulate a scenario, right, for the thinking process. Actually, that's more on the non-recurrent aspects of the skill, as this Professor Van Merenboren uses, right, the non-recurrent aspects of the skills. Yeah.
No, I totally agree with you. Nobody can claim that one solution would solve all the problems in medical education. Yeah. We need the lectures, we need the simulation labs, we need the skill labs, we need everything. CyberPatient is an additional tool to support the decision making, and it improves the experiential learning to give the students this compiled thinking from the time patient comes to the time patient goes home. So if the students will go through this experience like 100 times, when they go to the clinics, they would know exactly, oh, I'm not going to describe this medicine to this patient. I was wrong, like you would have it in their, recall, recognition, semantic neurons. That's what we're trying to do, trying to bring an experience that is similar, not exactly the same, but similar to the conceptually similar to the decision in the process that they go through in medical school, so that we can have a safer environment. And also, some people, to tell you the truth, in some countries, I have been talking internationally a lot, and some people say, oh, we have a lot of patients, why would we need that? I mean, that at this stage of development of technology, it's very unethical to say we're using patients are good to use for whatever, and I think it will be very important in the future when the patients got educated and say, I mean, we're not. So let's put one simple example. You're not going to fly with a pilot that hasn't been done 500,000 or virtual flying, right? But why would a patient allow a student to do procedures with them if they're not exposed actually in an alternative environment to make them understand better?
Yeah. If you don't mind, I just ask two quick questions. Number one is that your 120 patients, is that spanned across different specialty? And if so, each specialty, how many cases? And I presume these are kind of fixed cases. Are you going to add on more with time, or this is the fixed number of cases that you have? Number two, can the educator, right, mix and match, different components, to put, because you have abdominal pain, it can be an ONG course, can be a abdominal, can be a GS course, And the third thing is, what is the purchase line for such a equipment? Yeah. Is it per user, or is it per machine, or what?
To answer your first question, perhaps you know better than me, there's 1,600 classified diseases in the world, and we cannot cover everything. And in medical schools, they do not cover more than 120 cases. So the 120 cases that we have chosen is based on LMCC objectives. It's the Canadian Licensing Examination objectives. So these are the cases that are important for Canada. However, we understand that some of these cases might not be important in other parts of the world. So to answer your questions, yes, at this point, we have a system-based platform. So we have cases between 8 to 12 to 13, depending on how important that is, depending on those learning, LMCC learning objectives. We have different cases for different parts, like GI, cardiac, neuro, OBGYN, pediatrics. We cover everything. Musculoskeletal, we cover everything. But having said that, this is just the beginning. We continue every day putting more and more cases, of course. But the most important part of your question is that when we have a partnership with a university, we emphasize on two things in that partnership. One is to develop cases that they like to have. So that is customized to their needs and cultural environment. It's also specific pathologies. So we build together cases for them, one. And second is that we would like to support and promote research with that partner, because CyberPatient is a disruptive technology, and you can do enormous amount. As you saw, I showed it to you in Japan, in Russia, everywhere we do a lot of research. So it opens opportunity for scientific methods in research, opportunities for faculty members also. So yes, so is that answered your questions, or your second question was a bit different?
Yeah, I think you kind of answer it. The only second one is the I guess that one Mark may be the better person to answer about what is the model of financial model for the purchase of such an.
It's a subscription-based. It's a subscription-based financial model, and if you're interested, my business development director Mark Ritchie can offline talk to you about how we can accommodate and support your system.
Yeah, and I appreciate the brochure set out. I think we can read through and see probably some of the information that I want is probably there, I presume.
Yes, yeah, the information is there, but you can also contact Mark, and Mark can talk to you, and we have different options, and we're here to support. I'm a professor more than a businessman, right? I've been a professor all my life, so my aim is to support education to the point that we cannot hurt ourselves, right? We're also a business, but we will do whatever to support medical education, depending on environment, countries you are, what we can do to support. Also, you didn't see that, but yet the platform is translated in 72 languages. So any language. I saw a few minutes ago somebody from Georgia. I know Georgia very well. I love Georgians, and I've been in Georgia many times. So yeah, it's translated. Yes, sorry, but it's translated in any language you want, in Russian language, in Georgian language.
Yeah, there is a Georgian language at your language list. Yes.
Yes. It is translated in 72 languages, and also we can support. You know, we can talk. That's what it is. For me, it's the education environment to enrich the education environment for students. We are now in 125 countries around the world, and 300 universities are using Segmentation. Any other questions?
It's wonderful. In future, you can do also for clinical residents, for example, for pathology slides to make diagnosis. So many cases for pathologists, cytopathologists. So to be more just specific for a different clinical residency as well. So
absolutely. What we have right now, do you know that Canadians are going into a competency by design curriculum? In competency by design curriculum, it requires a very sophisticated assessment methods. In the past, we allowed students to go to residency training program by multiple choice questions. Nowadays, the American College of Medical Education in the Canadian Association of Medical Colleges, Medical Universities, they come up with a new assessment tool. It's called EPAs, Instructable Professional Activities. So that does include not only a case that we demonstrate, it also includes communication skills, it includes M&M round, it includes consultation, it includes talking to patient, how to talk to the family of the patient and all that. So we have, there's 12 EPAs in Canada and 13 EPAs in the United States. And we have now a patented CyberPatient platform for EPAs, to answer just your question. So we're in the process of now negotiating with the Royal College of Physicians and Surgeons of Canada to make this EPA-based learning process for residency training program. We also have separate communication platform, just for communication. It's very important for students to learn. And also, we have team training competency platform. Because so there's, in my opinion, there are two major problems in medical education. One is the discrepancy between theory and practice of medicine, where CyberPatient in other simulation environment can bridge that. And also there is a discrepancy between individual training and team performance in the hospital. The nurses are trained separately, doctors are trained separately, and when they go to the hospital, they have to work as a team. And seldom that environment fails because they didn't work together. They're good nurses, good doctors, good allied health professionals, but they never work together as a team. So what we do now is we use physical simulations for team training. We have a mannequin, and around the mannequin we form a case. The people go there, they do the team performance, and then they go into a room for debriefing. You perhaps know all that, right? So what we have done is we created an avatar-based platform. It's a 3D avatar-based platform where the teams can be from any place from any part of the world. The nurses, doctors, anesthesiologists, whoever other people are there in the team, and they can work together and actually debrief together in a virtual environment. So those things are coming soon. We have patents on them, and we're just about to launch them. Yes, thank you very much for your comments. Yes, we are thinking to do residency training program and team training program as well.
Sorry, Dr. Qayumi, I see that Dr. Saldana also has a question for you.
Yeah, I'm a lecturer at St. George's University of London, and I teach both medical students and physician associates. So I guess I can liken CyberPatient to our PBL, so problem-based learning, where we'll do discussions and clinical reasoning and all of that. Now, I think our students could benefit from CyberPatient, but I don't think it's something that all of them would need. I think it would be the students that struggle with clinical reasoning and the weaker students that need a top up to what we are already teaching them. So that's why I ask whether students are able to access this independent of the university purchasing it, because I don't think all of the students would actually require it. So that was kind of what my question was based at.
Yeah, maybe that would be the matter of dispute to say whether all the students need it or not. Because when I was a student, I remember I was the best of my class. And when I went to the emergency room first time, I was crying. I didn't know what is what, and I didn't know why we were taught backward in our books and lectures. So if you remember, our lectures in books and everything in medicine is etiology, pathogenesis of the disease, signs and symptoms of the disease, and then diagnosis and prognosis of the patient, treatment and prognosis of the patient. But when we go to the emergency room, you have to think backward. People are not coming with etiology. You have to rethink how the people are screaming from pain, and you have to connect that to the etiology and think like how it's done. So
but we are doing that in problem-based learning. We are working backwards,
yeah.
And we also have ways of, for example, you could kill the patient if you give them the wrong dose. So yeah. I wonder if you have this sort of thing on your platform, you know, where things can go quite wrong depending on the choices that the student makes.
Yes, absolutely. Absolutely. That's what Dr. Shariar showed you, the level 4. When you do the level 4, 3 mistakes, the patient dies. Mm-hmm. You have to go and start from the beginning. So I totally understand, and I appreciate your comments about using CyberPatient for PBL and CBL. Yes, you can use that CyberPatient for PBL and CBL. It's a case, you know, like I've done a lot of PBLs in my past life and in CBL also. So it's a good tool for that. But what we are talking about the compiled thinking. We're talking about experiential learning. We're talking about familiarity of students forming those semantic networks in their brain before they touch a patient. So that's a separate discussion. But coming down to your second question, right, or the continuation of your first question, yes, we have. You know, our experiment in Japan that I show it to you, and Mark, can you please send that to Lisa? That research, even in it's 2004 and it was published. So what we did is we had 4 groups of students in 2 universities, Jichi and Kochi University in Japan. So one group of students would have CyberPatient, other group would have textbook, and another group would have CyberPatient with textbook, and the other group was sham. They went through pre and post tests, but they did not do any. And the pre and post tests we did with multiple choice questions and also with standardized patient, okay? So it showed actually a significant increase in their knowledge and abilities. But you're absolutely right. I'm coming back to say that you have a point there. When we did that, I said, I'm not satisfied with this results. I want to know that the performance of all these students in the medical school in general. So I got the scores of all the students. 10% of the students that are top of the students in both of those universities, it did not matter if they use CyberPatient or the textbook. Absolutely. But the other 90% that were mediocre or low achievers, they were really boosted. CyberPatient boosted their performance very, very much. It goes back into the style of learning, right? It goes back into how do you learn through audio, visual, through tactile memory? How do you learn? So I would believe that it is. I personally believe it's a very important tool for medical schools to improve the style of learning, to improve the educational process, to give this to all the students. But you're right, 10% of the students, they're not going to benefit from this. They're going to benefit from anything. They can read things in the metro, in the subway, and they come out as a subway and they know it. We know those people. But the world does not consist of those people. 90% of the people are mediocre achievers and lower achievers because they have different. They're not stupid because they all went to medical school. They're the elites. But still, amongst the elites, you have differences. Mm-hmm. I answered your question.
Thank you very much.
You're most welcome. Any other questions? Okay, if there is no, I think we went over time. Yeah, it's very good. Thank you very much for participating, for your interest. I appreciate AMEE conference organizers and Gabriella for giving this opportunity. And please be in touch with us. We'll have our emails. You have our contact numbers. We'll be more than happy to help and support. So at this point, if there is no other questions, I would like to say goodbye.